So I'm going to move on now to our panel. I'm going to invite Sir Bruce and Professor Bewick up to the seats here. And Naomi, unfortunately, wasn't able to join us in person, but you can see her on the screen. And hopefully, Naomi, you can hear us now. So I'm going to invite all of our panellists to introduce themselves. Of course, you've all had their biographies, but I think there's nothing like hearing from the panellists themselves. So Naomi, would you like to lead off? Who are you and where are you from and what are you passionate about?
I'm Naomi Eisenstadt. I'm chair of Northamptonshire Integrated Care Board. I am passionate about health inequalities, and I'm particularly passionate about poverty itself and child poverty.
Thanks, Naomi.
Mike Bewick, I'm a GP by background. I was formerly his sidekick at NHS England some time ago. And I now am really passionate about training in the new workforce. And that's probably where I'd like to stop at the moment.
My name's Bruce Keogh. I'm chair of the Birmingham Women's and Children's Trust in this city. Prior to that, I was a cardiac surgeon. I was a professor of cardiac surgery at UCL and medical director of the health service for about 10 years. I guess, two areas I'm interested in are the measurement of clinical outcomes, and I worry about the retreat of the focus on quality in the NHS.
Thank you. So I'm going to invite Naomi to lead off first. So each of our panellists is going to just give a little overview for 5 minutes on their area of passion and concern. And then we're going to take questions from the floor. And let's make this a conversation. Yeah. So a number of you have pre-submitted questions and I'll call those people out. So hopefully you can actually remember the question that you put in 2 months ago. If you can't, don't worry, I've got it here. But I'm going to invite Naomi. So Naomi, could you share with us for 5 minutes your thoughts in respect of integration and ensuring that the people who need the services the most have equitable access to them? And also your views on whether closer collaboration between systems is actually going to begin to address the issues of poverty. So over to you, Naomi. Floor's yours.
All right. Thanks very much. I'm really sorry I can't be with you. And boy, could I speak longer than 5 minutes on that question. So I'm going to divide my 5 minutes into 3 areas. First of all, I think that we use the language of integration and collaboration too loosely, and each of us has a different think bubble about what it means. And for me, the most important thing about integration and collaboration is the way that frontline workers work together in the interface with the end user, patient, pupil, child, whatever. But I do think that the way in which we try to restructure to deliver integration and collaboration takes us into a whole area of very complex arrangements. And fundamentally, the most important part of collaboration is how well professionals on the ground working with people respect each other's contribution, believe that they each have a valuable contribution to make, and don't think, gee, if only there were more of me, everything would be all right. I think in terms of reaching the people that need it most, it always makes me smile because I think basically we want people to want what we think they need. And the reason that we don't reach people that we think need it the most is because we're not actually trying to figure out what they think they need and doing an open negotiation with them on what they think their issues are, as opposed to what we think their issues are. It doesn't mean that this should be a knowledge-free zone. It doesn't mean that you don't share it. It doesn't mean that you do everything that the end user wants. It does mean that you have to understand the context in which they're living to understand why sometimes people are resistant to our services or our advice. Sometimes it just doesn't suit with what they think is important to make their lives better. And the third bit I want to talk about is that final bit about working together with integrated care systems. One of the things that really surprised me when I took on the role of chair of an integrated care board is that I thought the main job was about bringing together health and local government social care. And I didn't realize how much of the job was about bringing together the internal bits of the NHS itself. Now, my own view is that the real important working together is between local government, between place and the NHS, and that ICSs should be working together where there are tertiary care needs, on IT systems, on those things where a much bigger footprint really counts in terms of efficiency and also better services. But I think that I don't think that systems should be working together at the cost of the way in which an individual ICB works locally in terms of local government. And we are very lucky in Northamptonshire. We only have 2 local authorities. We have 2 places, which makes that working together much more intimate, much closer. We meet weekly. Both chief executives are on my board. So I think there's always a tension between what we're trying to do 2 things at once, both of which are vital, but being clear about which one is suitable for which aim is really important in the extent to which ICSs work internally with local government and the NHS, and where different integrated care systems work across on a larger geographical footprint.
Naomi, there's a load of food for thought there, and thank you for the pace with which you delivered that. It was almost quite difficult to take it all in at once.
We've had it.
Yeah. Should we go? Thank you, Naomi, and I know you're going to get lots of questions. So I'd like now to move on to Bruce. So Bruce, you've been at this game a long time. Sorry, I'm not making any observations there. Could you share with us your thoughts on what integration actually should mean? Yeah. And perhaps some of your thoughts on the domains that could make integrated care really move forward as a coalition of the willing.
I spent some time working in the Department of Health, and there were interminable meetings on integration and slide decks produced by McKinsey, which were half an inch high. And then one day I was meeting with some mothers of children who had varying degrees of disadvantage. And the meeting went on for the best part of 55 minutes, we getting towards the hour, and they kept on saying, you need to focus on integration. So I said, actually, what do you guys actually mean by integration? And there was a pause, and then one of them said, not having to repeat ourselves. And I found that quite an insightful observation, because we run a pretty fragmented healthcare service where everywhere you go, you're having to not just give your name, but tons of other details. And things fall between the cracks. So I think integration starts with making the journey for those people that we're trying to help more convenient, easier, simpler, and with less fractures where things can fall between the cracks. And the second definition, which I think is kind of helpful to start this conversation off, is what do we mean by inequalities? And people write theses on these. And we need some kind of simple understanding of it. So in my head, an inequality is an avoidable, unfair difference in outcomes at a systemic level for different people in society. And I then find myself trying to think, how can we use integration to try and address those issues? Perhaps we'll draw that out a little bit more in the conversation. But one of the more challenging things I got asked many years ago by Andrew Lansley was develop an outcomes framework for the health service. It was beyond my comprehension, but fortunately, Mike and I also worked with a very smart guy called John Stewart, who came back one day and said, I've got it. He said, there are 5 things that a healthcare system should do and do well. Now, I'm going to argue that there should be a 6th. And the first is that a healthcare system should stop you dying from things that it can. Now, you've already heard Andy Street implying that a lot of the major determinants of mortality lie outside the jurisdiction of the NHS. We probably affect somewhere between 10 and 20% of that. So things like stroke, heart attack, cancer, we can influence. The second thing is that the health service should help you live well with a long-term condition, whether that's dementia, rheumatoid arthritis, asthma, something that's not currently curable. The third thing it should do is look after you well when you have a short episode of illness, whether that's a broken leg, cataract operation, measles, whatever. The fourth thing that it should do is that it should treat you decently. And I have to say, we are absolutely rubbish at that. We don't offer the kind of customer service that everybody in this room expects from every other industry. And then finally, the system should treat you safely. And by safely, what I mean is that when you're talking to a patient, they understand the risk of their disease. They understand that their treatment might carry some risks, and they make a value judgment. Do I want to have surgery or not, for example? What they should never have to take into account is that the way that we organize and design our services, or the way we fail in the integration of services, will adversely affect that equation. And then finally, I would just add in safety that inequalities, in a way, they cross all of those domains, but they also play into the safety domain, because if people aren't getting access to care, if they don't know where to go, their outcomes will be different. And that's as a consequence of the way that we organize our service. So I think I'd probably... Oh, the sixth, thank you. The sixth thing is, and I raised this with Andrew Lansley, I said, one day someone's going to stand up in Parliament and say, oh, the NHS just costs us money, it doesn't really do much good, we need to spend the money somewhere else. And I said, we should have a sixth domain, which is economic benefit of the NHS to the economy, because we're a tax-funded system. So we're utterly dependent on how well the economy does. If the economy does well, the health service does well. If the economy doesn't, the health service doesn't. And there are a number of voices around the country who argue that the NHS just costs a shed load of money and makes no real contribution. And I think that's a kind of superficial argument, because the health service employs, well over 1 million people. All of those people pay taxes. It then buys kit, all sorts of expensive kit from companies who pay corporate tax, who employ people who pay personal tax, and those people spend money in the economy. And there is an argument that investing in health is actually investing in the economy as well, particularly in a tax-funded system. So I think that also plays into, if you like, the inequalities agenda, because if you look at people at the higher end of the socioeconomic scale, they're less dependent in some ways on the health service, because if the health service doesn't work, they go somewhere else. But for people who are not in that position, they often come from backgrounds where there may only be one person earning in the family. They have transport difficulties. They have all sorts of other problems. And we owe it to help them, because if we don't help them, their whole family suffers economically. And if they suffer economically, equally our local economies suffer economically. So I think I'll stop there and hope that I've said enough stuff to provoke a conversation.
No, I think your point's really well made, and I particularly, that one on transport really resonated with me. We did a piece of real-world work for Greater Manchester about 4 years ago now, and the medical director there had said, I've got a hunch that the doctors in Stockport, Bury and Burnley are hanging on to their women with breast cancer for too long and not sending them forward for Christie care. Can you prove it? And so we used multiple data sets. So we used hairs, we used our own prescription data, but we also used Google Maps. And we found out that his hunch was absolutely right. These women were being diagnosed later. They were not getting access to NICE approved drugs at the right stage of their treatment. But it wasn't that their doctors were hanging on to them in inverted commas. It was, when you look at Google Maps, it's 20 minutes to the Christie from Bury, Bolton and Stockport as the crow flies. But these women aren't crows and they don't fly. And that was why their doctors knew they wouldn't travel. They wouldn't be able to travel. They wouldn't be able to make it across the city. So they re-engineered it and took Christie care to Bury, Bolton and Stockport. But that kind of, that economic piece is a really important play. And, I said at the beginning about how much investment we attract in to the UK. Yeah. And it's not to be underestimated. And people who are in clinical trials have better outcomes than those who are not.
Yeah, and much of our inequalities really are driven by access.
Yeah. And I really liked Naomi's point there, because I thought that really played in well when she was talking about, us not really checking about what really properly checking what people need, as opposed to assuming that we know what they need. And I think that plays in really nicely. Mike, I want to come to you now. Last but by no means least, would you share with the audience your thoughts on the opportunities and challenges facing integrated care systems, and kind of 3 themes I know you want to call out: workforce, culture, and delivering on public health? And I'm really glad that you put culture into it.
Okay. But I couldn't go through any talk without mentioning culture at the moment from what I've been doing of late. Firstly, to say it's not an enviable position to be in, to be running an integrated care service at the moment. It really isn't. You've come at the back end of a pandemic. You've come when there's a workforce crisis. You've come when there are strikes within that workforce. And there's a great disenchantment nationally with some of the services that we provide. Yet we provide universal services from cradle to grave. That hasn't gone away, but we've got something missing at the moment in how we're delivering it, and people want us to think differently about how we deliver it. There's a commitment now from both parties, I think cross-government now, cross-party, that we need to increase the workforce, that it's fallen behind the numbers that can produce, and going back to your point, a safe service requires access, it requires trained people to deliver healthcare. Fundamentally, the inequalities will not get better unless we set the scene there. And the workforce that I'm looking at the moment, because I'm trying to set up a medical skill at the moment, is one where we're trying to attract people into what superficially looks like an unattractive career at the moment. Now, it's interesting, we did some market research with students who are currently studying across the UK in different medical schools. And actually, if you talk to them, they're very optimistic about their futures. But they want it to change, that training to change. They want to be more involved in how the structure of the health service works. They want to know about how to get into leadership positions within the health service. And they want that research that Angela strives to bring to this country to partake in it as early as possible, and to see their education as a longitudinal thing, not one that ends at the end of a training program and their speciality. And talking to them was quite refreshing, because it made me think that maybe some of the design that we've got around placements, for example, that could actually be helped across an integrated system, because we tend to send students to a surgical ward, a medical ward, a paediatric unit. Why don't we send them on a patient journey that looks across the system, so that they would understand what it was like to be a patient? And you're quite right, people hit these gaps, and you have to duplicate everything. Now, to do that, we need a better digital system. And yesterday I was at a company with Ben. We were given a short seminar yesterday on how to integrate some of those digital systems. Now, those students, they integrate everything digitally. Everything is on their phone. Everything is on their computer. They don't study like I used to study in a library with index medicus. They sit there and have the world at their fingertips. What they want are the relationships with professionals about how they learn their crafts. And they're very instructive. It's a bit like asking patients to co-design with you their care plan, or their carers do their care plan. It works a lot better. But the other thing that they did identify, and having interviewed a lot of junior doctors in the past year, and very senior doctors, some very local to here, is that sometimes they're just not felt that they're listened to by the management structures that are imposing and implementing new policies. And if they did, as during COVID they did, and they're all passionate that during COVID, it released them from some of the governance issues that were inhibiting them from change. And they all say that's down to the culture of the organization. And when the culture is wrong, the culture it becomes almost an ascetic force. It causes the dissolving of confidence in a team, and people leave. They either leave or they get into trouble. And they get into trouble sometimes because they've taken their eye off the ball, they do something wrong, and they end up going to a regulator, And that is very, very difficult for them. We lose a person from the system, often for up to 2 years. My record has just been beaten for somebody who's been off now for 6 years while under investigation. And things like this happen all the time, and people lose confidence in the system. And yet all these people are dedicated every day going in and trying to make a difference. But they are looking over their shoulders and worried that this culture is not going to improve. And we've heard both from reports coming from the BMA, from the GMC, we've heard reports coming locally about bullying cultures, which have been really quite difficult to deal with. And people have responded by either leaving or whistleblowing, and those whistleblowers have not been looked after. And interestingly, the students will say, we see things on the wards that we're very unhappy about. We think that that's unsafe. Now, the GMC, of course, wants those people to report. They're having confidence at the age of 19, 20 to come forward to do that. We need to make it a permissive environment for people to report and to make sure that they can be heard. And my last point is that the inequality side of this is we describe inequalities, and I take the definitions are difficult sometimes. We describe them, but we don't put things into place that are actually going to make a big difference at an integrated level. So your child that goes to the GP 3 or 4 times, and there's a problem with the home life, there's not much connection anymore with that, with the social environment that they're in. That changed some time ago. I think probably changed after Ken Clark's initial legislation. But there's got to be a joined-up version of public health that makes it happen. Now, I think we've got loads of public health policies coming out and recognizing where the challenges are, but we're just not very good yet at how we actually implement those policies in a uniform and systemic way. Otherwise, as Bruce says, that systemic failure comes back to haunt us in the data that comes out and shows those differential outcomes. And I think I'll stop there.
Thank you. Bruce, I know you wanted to make another comment on workforce before we go to questions from the floor.
Yeah, I just wanted to be a bit provocative on workforce, if I may. When I hear people around the NHS talking about workforce, it basically boils down to recruitment, retention, and return. And somehow the idea that if we just carry on doing what we're doing now, we'll get enough staff. I don't accept that. If you look at data coming out of the World Health Organization or the OECD, there is a clear indication that worldwide, in terms of healthcare workforce, we're going to be somewhere between 16 and 30 million people short by 2030. Now, that's only a few years away. We are not going to be exempt from that. So continuing just to think that if we try harder in this workforce space that we're going to solve the problem is to delude ourselves. And that's going to mean some cultural changes, it's going to mean some technological changes, and it's going to mean some changes in the way that we think creatively. And I think that partly came to mind. I was visiting Korea and I was on an intensive care unit there. And they had a nurse staffing ratio in one intensive care unit of 1 nurse to 2 patients, and in another intensive care unit, 1 nurse to 4 patients. And I said to them, we'd never get away with that in the UK because we've got a whole bunch of kind of ingrained standards which can't be breached. And they said, well, we had the same problem, but we just didn't have the people. So we either didn't look after people or we changed. And I think we're going to have to do the same. And I think technology offers a route into that. It's not the solution, the complete solution, but it offers a route. And I was speaking to someone from the Cabinet Office yesterday, actually, and they had been doing some work for the Council on Science and Technology and interviewing people about technology. And someone had said, the NHS shouldn't be spending money on technology, it should be spending it on patient care. And I just thought, really? You know, because the two can, funnily enough, go hand in hand with the very people who look after their health on their iPhones or whatever.
100%. And that brings me rather beautifully, very good segue actually, to one of the first questions from the floor. Is Callum Coburn here today? Callum, hi. Can you remember what your question was? Because I've got it. Well, let's get a mic over to you, because I'm going to give you the first few lines and then you see if you can finish them. How about that? So can we have the roving mic over to Callum, if you put your hand up? And Callum is a project engineer with Synoptics Limited, I believe, correct? Roving mic, where's it gone? So Callum, the first few words were, how do we ensure that new software and systems products meet the
requirements?
Yeah.
There we go. So yeah, how do we actually deliver on the requirements of people on the front line? How do we communicate those requirements back up? How do we incorporate the requirements of everyone involved in that whole patient journey? So pre-interaction with the health service, post-interaction, and during, and then all the kind of management requirements as well. How do we pull it all together and deliver something that actually works, rather than kind of a bodged solution that is a compromise on too many fronts?
Yes, I quite liked your finish. It was, and doesn't simply add to the technical overhead of the NHS technology estate. So, how do we ensure that new software and systems meet the requirements of frontline clinicians? Who wants to take that?
I'll start, but you can finish. Yesterday, we were with a company that produces both software and hardware for integrated services. Their way of doing it, and I think is the one I suppose is reasonable, which is your customer and you ask them what they want, and what's their requirement. Often people come to me with great new bits of tech and say, how can the health service use this, as opposed to let's develop the tech to help the health service. And you need someone who helps you negotiate through the vast array of regulations and procurement requirements. I'm sorry, but it's never going to be easy. And as those change periodically with new regulatory standards, etc., you need someone who can keep you up to date with that. And the third thing is, I think you just need people who are willing to be less risk averse and to take it on with you, so that actually you can do those initial experience work and then report back in a reasonable time, so that you as a company or as an organisation can make investment decisions about whether you're going to continue to serve the NHS. And at some point you need to have a discussion about, is this really adding value, or is it just a nice other clever thing that we can do?
It's a complicated question, and as I thought about change in the NHS, I came to the conclusion that you can affect change if you can accomplish two things. If you can demonstrate that whatever you're offering will improve the quality of care, that'll get you somewhere. If you can demonstrate that it'll make the lives of people delivering the service easier, that'll get you somewhere. If you can do both of those, you've got something that's potentially unstoppable. So I think that also applies to the question that you asked. Actually, the one thing that people really worry about change, they don't worry so much about the change, they worry about what they're going to lose. So if you can demonstrate with your software that it does those two things, that it improves the quality of care that's on offer through a variety of different lenses, and that you can prove that it makes people's job easier rather than, as you say, adding to the tech overhead, then I think you're onto a winner. But then you run into the roadblocks around procurement, and that's a whole separate issue. I don't think we want to go into procurement, but
no, let's not. Naomi has been very patiently sitting with her beautiful yellow hand up.
Well, I have a very, very quick answer to that. I mean, in terms of how unbelievably difficult it is, because for 15 years, we've been trying to get the Department of Health and the Department for Education to agree that there should be one NHS number, not a unique pupil identifier and a different NHS number. And unless you get agreement on systems to collect data in the same way, you'll never get the benefits of data and data integration. Second point I want to make, and this is again rather contentious, my experience with running Sure Start is that the most difficult people to get data out of was the NHS, and they wouldn't tell us where the new babies were born, so we couldn't do the visits. And I think the real problem is that if you really are interested in low-income families to get their benefits, they have to tell everybody everything about them. The data protection stuff, I think, is chattering classes. I think that it works against equity in health access.
You possibly can't see it, Naomi, but I tell you what, the head nods that were going on there for that forthright answer. Thanks so much. I've got a lot of questions on workforce, not surprisingly. Is Emma here? Emma Perry? Yes, Emma, would you put your hand up? Can you remember your question? No, okay. It starts with, what ideas or areas of integrated healthcare practice can be shared to support mental health?
It'll be about supporting mental health workforce.
Yeah. So ideas of good integrated healthcare practice, and to your points with regard to recruitment and retention challenges for inpatient and community health services questions. And Emma, I believe you're the divisional director at the Nursing Adult Mental Health. Is that Black Country? Yeah.
And it was kind of thinking about some of the work that I'd done in a secondment with NHS England around international nurse recruitment and the 50k target. So it's kind of, what I learned was there's really amazing best practice going on in silo. And actually, in terms of thinking about integration, how do we kind of share some of that best practice around workforce and mental health, and around the inpatients and community, not just one setting, and even third sector and social care.
So Emma, I'm not going to take 3 answers on that. Can I direct that question? Who would you like to answer that question?
Probably, I was actually really fascinated in, Mike, what you were saying really about some of the placements.
Thank you for that.
And also, well, now I can't just pick up one,
pithy answer,
but
Mike.
also, Bruce, it's kind of that bit about we are going to have a gap, and we're going to have to accept that there's this gap. So what do we do differently? And what could we do differently in terms of the placements and the skill mix and the opportunities for recruitment and retention?
Well, without wanting to go into a long lecture about how we could reorganise undergraduate training for just about everybody coming into less than 5 minutes. But I think there isn't an A answer to your question. But if you have good practice, we've been really bad at sharing good practice. And often when we do, people say, well, actually, yeah, but it wouldn't work around here, would it? You know, and it's a common throwback. And in fact, if it's that good and it shows that you can retain staff, then other people should be using that. I go back to the COVID experience again. When we had webinars during that, people were coming with best practice and people were repeating it. You know, but why should we just do that under real adversity when actually we've got a slow burn sort of adverse situation at present? So I think these willing people coming together to collaborate. There's no reason why they can't collaborate at a regional level and then at a national level. And I think that's actually for the leadership of the NHS to actually make sure it happens. And not just have a conference where you go along and say this is what we've done and whatever, but actually you will go out there and you will go and teach other people how to do it. That's how I do it.
I'm getting signals from the back about room moves that we're going to be doing in about 4 minutes. I'm going to just bring this session to a close, if I may. Mike, Bruce, are you going to be staying around or are you shooting off?
Depends on the questions.
Okay, well, what I'm going to say to you is it'd be great because I know there's quite a few people that have got lots of questions for you both. So Bruce, what would Bevan do with health and social care were he around today?
I think I'll shoot off. No. So in 1948, the average life expectancy of a male, and forgive me for just picking on a male, but the numbers were easy, was 65, which is retirement age. 50% of people dead by retirement age. Fast forward to now, where it's 80-ish, maybe just a little bit over 80. So suddenly there's a 15-year increase. And that brings with it a whole bunch of comorbidity problems and the frailty problems and what have you that you all know about. Now, the jurisdiction for the prevention of disease largely sits with local authorities, as Andy Street was pointing out, housing, transport, recreation, employment, so on and so forth. when that and vaccinations. And when that doesn't work and people become ill, the NHS picks it up. And then people go into hospital or into care of their GP. But then they get passed back into the local authority for social services and what have you. And I think that if Bevan came now, he wouldn't be arguing we'll have an NHS which will make everybody better, which was sort of the argument at the time. He would say we need a health and social care system. And I think well, I don't think actually, that is the underlying philosophy and the policy intent of the integrated care systems. The idea was to bring the local authorities and the health service closer together. Now, that's worked better in some places than it has in others. So I think that's what he'd do now. But
Thank you. So going from Bevan to Aristotle, Mike, and I'm going to give, I'm bringing Naomi in last. She had the first word and she's going to have the last word, which is, of course, a woman's prerogative every time. Aristotle allegedly said, give me a child until he's 7 and I will show you the man. How does this apply to public health strategy? Pithy answer.
I wish my wife was here. Naomi, you've probably done this, but my wife used to work alongside you delivering Surestat. So I got to know a lot about developing Surestat at that time and the travails of trying to involve my colleagues in general practice into spilling the beans on the data. So it was a very real problem. But what she taught me, and I knew from other areas, and I'm not a pediatrician by background at all, and actually it's about the best start in life is always going to decide your outcome in probably mainly in your health if your genetics are okay, but many other things. And I as a GP, I once read a letter which described a 7-year-old boy who'd been hospitalized, and a very brilliant pediatrician called John Willie Platt had sat down with him and realized this boy had really good computational skills. And in his view was absolutely outstanding intellect. I read that letter 20 years later as a GP. And this is not in any way to say an electrician isn't a great job, but he never went to university. He never achieved his potential. And that must happen so often. And it does describe what to me is a passion, really. That is, if you can wake up in the child that those educational stimuli, then that I think bodes well for our country.
Well, I'd then like to link that question very well to Naomi, if I may. And Naomi, I'm going to take kind of second half of a question that I wanted you to answer, is how do we strike that balance between investing in early prevention and supporting education for the poorest children?
Actually, I want to answer a slightly different question. I'm going to take the prerogative because surprisingly, I think the really important message is never too early, but never too late. And I really worry, I think it's enormously important to concentrate from prenatal right through pregnancy period, right through the very earliest years to get a good start. But it is not inoculation. Stuff happens. So we need to have a very good early years system. We need to have a very good primary care system. Primary school system. But we also need employment support that keeps people healthy. We also need much better prevention of falls to make sure that people don't. At every stage in life, you can prevent downturn in the next period to prolong healthy life. So I think that an early intervention approach is a life cycle approach. It's not just an early years approach. In terms of the poorest or low income, it's really about understanding what people need, understanding the context in which they live their lives. And I'll just do my best line on it is, if you want me to take a parenting program, have it in a free laundrette, because if I can do my washing at the same time, I'll be very happy to learn how to be a good mother.
You know, I'll have to give her that one.